Okay, I'm going to start us now. I think we've still got a few people coming in, but I think it's probably worth us getting going. So I'm Saffron Caudry, and I am Interim Chief Executive at NHS Providers, and I'm delighted to be chairing today's session. And just to give you a little bit of information, so we are recording today's session just so that you are aware. And we, NHS Providers, are the membership organisation for trusts and foundation trusts, and our role as a membership organisation is to support you, our members, to deliver high quality patient focused care by supporting learning from each other, acting as a public voice, and also shaping the system in which trusts operate. And what we are doing with this health inequalities programme is supporting members, trusts, to make sense of health inequalities and actually embed it as part of core business. And we are using resources which have been developed, informed by our research and engagement with trust leaders over the past year, looking at really what you've told us what you want to hear, and so we've reflected that in this programme. This is the second webinar we've run. We've been really delighted with the level of demand for these webinars, and this one is going to think about how we support staff to contribute to reducing health inequalities by really understanding how frontline staff witness and experience health inequalities. And we're going to explore the role of education and training in building clinicians' understanding of their role in this area through their day-to-day practice. And it will also look at how boards can gather insights from staff to strengthen their own understanding of the kind of action that trusts can take to address inequalities in healthcare. Please do have your microphones muted throughout unless you're going to ask a question, and we will have time for questions at the end of the presentation. So please do save your questions for then. And we've got three speakers today who I'm delighted to welcome. So we've got Dr. Esther Miraku, who is a consultant in public health at North Tees and Hartlepool NHS Foundation Trust. We've got Dr. Maslar Amin, who is National Clinical Advisor and Associate Director, Health Education England, and is also a GP. And we have Carolyn Regan, who's Chief Executive of West London Mental Health NHS Trust. So if you wish to ask a question or come into the conversation, please use the raised hand function, which you can find at the bottom of your screen. Please use the chat function if you want to add to the conversation, and any unanswered questions that are in the chat will be taken away and answered after the event. So we've reordered the agenda a little. And we're going to ask Dr. Maslar Amin to speak first. His focus is on how we increase the skills and capability of staff to improve population health and reduce health inequalities. So I'm going to hand over to you now, Maslar.
Thank you. I'm just going to share my screen. If you just bear with me, please. Yeah, you can all see the screen, full screen. Yes, thank you for the introduction. So yes, I lead population health and sustainability at HEE, and I'm also a GP in my other job. Thank you for rearranging the schedule. I'm in clinic today, and yeah, there's not that many of us as normally there is on a Wednesday. But yes, so I'm going to be talking to you about how at HEE we're trying to bring population health to the front line. So we need more population health approaches in the NHS. The evidence is clear, the policy is clear, the NHS long-term plan is very clear in its messaging. The NHS Future Doctor report was also very clear. If you look at the NHS principles, 5 out of 7 center around population health, and also last and not least, it's COVID-19 was very clear that we can't leave population health to just the public health workforce. So what are the benefits of population health? So it's aimed at improving the health across a whole population, and it addresses the physical and mental health outcomes, and is centered around well-being, and it's focused on reducing health inequalities. There's also action to improve prevention and also tackling the wider determinants of health that are so important for outcomes, and also working with your communities and partner agencies. So what are we doing at HE? So we're outlining 2 levels of practice, the enhanced level practice in population health and the advanced level practice. Now I'll explain to you how they differ and what we're doing around both. Let's first start off with enhanced level practice. So in 2020, just before the pandemic actually, we launched the first National Population Health Fellowship for NHS staff. It's a truly multi-professional program that recruits across the health and care workforce in line with ICSs. It was launched to effectively have a model where we can constantly grow the number of healthcare professionals with the skills and capabilities required to deliver population health. It's all well and good saying ICSs need to do population health, this and that. It's not like the workforce is going to wake up on a Monday morning and have all these skills. So we've got to give it to them. So the fellowship is around, the focus is for the fellows to improve health outcomes for populations, address well-being, prevent long-term conditions, and also this is all around centered on health inequalities. Now, what actually happens on the fellowship? So we get clinicians and managers and others who have a role relevant to population health, and we get them out of their normal job for 2 days a week, and they go on a population health placement, and they try and improve a health inequalities issue through a population health approach. So in addition to this placement, they also have a talk program that gives them that theoretical knowledge of what's public health, what's epidemiology, etc., etc. So when we first launched the program, this was a face-to-face talk program, and you get people from all across the country coming in and meeting, whether in Birmingham or London. But due to the pandemic, we did change it virtual, and the fellows have said, please keep it virtual, it's much better. So it's not one of these fellowships where you come and fellowships can be a bit more relaxed than a normal job, but it's an intense program. You're getting crash course in population health. So it's a development program. We set the fellows lots of homework, and they do lots of learning. Now, this is a picture of some of the cohorts we've had so far. We're now in our 3rd cohort. It's a new program. So far, we've had about 80 people through the program, which of course is not something that's going to change the population health landscape for the NHS, but we're getting there, and it's there to build up the fellowship and get more and more numbers going through. So this slide is more about the different professions we've had come through the program so far. You name it, we probably have had them. Pharmacy, this is like a little game for me now. So what else is going to pop up? Nursing, we've got managers, speech and language, pharmacy, physiotherapists, doctors, paramedics, dietitians, dentists. So we've had a good mix of different professions, which is, in the true ethos of public health, which is a very more professional workforce. This program is also multi-professional. So what further developments have we had due to the fellowship? The fellowship is very popular, and that isn't to brag. That's just to show that actually the workforce do want to learn about population health and health inequalities. It is particularly most popular amongst GPs, which is a good thing because they have an important role in population health, pharmacists, and allied healthcare professionals. We now actually have a pilot where we have GP trainees who are doing the fellowship as part of their training. And this is possible because GP trainees already get public health rotations, population health rotations in their training. So what we do is we work with them to really make sure that placement is of the same quality and experience as what they would get on a fellowship. And then they also come onto our learning program and get that theoretical content that they wouldn't normally get with their GP training. So it's a pilot and we'll see how it goes. And again, similarly, we're looking at other people who do public health rotations and whether we can work with them to make sure those placements are high value, and also whether they want to utilize our learning program to give them that theoretical knowledge. We are working to get the learning program accredited. So that's a process that's going. And increasingly, we've got systems effectively sponsoring their own staff to come out, because they know the limited places we have is very competitive to get onto. And the main cost element is the 2 days a week salary backfill that we have to do. So some systems are saying, actually, we've got somebody who's already on a population health placement or project, and we'll give them the salary support for the 2 days a week. Can they come onto your learning program? And we're increasingly getting that. So we've got different routes into the fellowship, and hopefully it will grow and evolve. So the fellowship is sat at the enhanced level practice. And I'll show you how the enhanced and the advanced clinical practice fit in with what else is already available currently in NHS. So let's talk about the advanced clinical practice. So, which I'll refer to here as an ACP. So, as well as the fellowship, HE have also launched a ACP in public health. For the sake of this talk, I am using the terms population health and public health interchangeably. There are some subtle differences, but I won't get into definitions, otherwise we'll be here till next year. But yeah, so again, this is a core capabilities framework that we have launched. So this has been launched and is due to be implemented. The ACP, compared to the fellowship, is characterized by a higher degree of autonomy and complex decision-making. So these individuals are people who are training to go and be independent. Yes, and it's in terms of the learning, it's more set around level 7, which is the master's level. Now, compared to the fellowship, there's still questions as to whether the fellowship is a level 6 or a level 7 qualification. So the ACP, similar to the fellowship, again, is around incorporating population health into work systems and the front line. It is there to, again, develop capability to promote healthcare policy, influence health inequalities, and effectively make sure there's as many population health approaches in the system as possible, things like population health management. So what's the vision with these two programs? So there is a great subject matter overlap between the two programs. And together, they effectively demonstrate one way of a population health development pathway for healthcare professionals and a potential career escalator sitting amongst what else is already out there. So the individuals who do the fellowship will be able to progress and go up to the ACP level if they so desire. And this is the little triangle I've drawn on paint. Sorry, I've got a cold as well. I need some napkins. But yeah, so this is a triangle I've drawn. So we do have more artistic, more talented people working on something more clever. But effectively, if you look at a public health consultant, which is there at the top, they can do everything. Now, traditionally, what you've had practitioners working with consultants. Now, if we can't just have this workforce doing population health. We need the wider workforce to do more. So the population health fellowship is here at the enhanced level. And then you've got the ACP here. Now, compared to a practitioner, an ACP can do everything a practitioner can do and more, but not necessarily everything a consultant can do. Now, when we've did the framework for ACP, they worked backwards from the consultant, the curriculum you need to undertake to become a consultant. So immediately here, you can see we've got a bit of a skill mix. We've got more people doing more in population health. We'll always need our consultants who are the experts and can do everything. And we'll have the practitioners. But now we have this more capability, this level of population health capability in the workforce. And hopefully this will then allow ICSs to tackle population health and improve population health and address health inequalities. What else have we got available? As much as I would like for the whole NHS to do a fellowship on ACP, that's not possible. It's not required. So what we've also created a toolkit on ELF. So anybody who has an email can access this for free. And this is really a set of resources blended, and they all come in different shapes and forms. And it's based around the learning outcomes that the fellows, National Population Health Fellowship, undergo. So here you can immediately, anybody in the NHS or in social care can go on this platform and get a bit of an introduction into what population health is. You can read about epidemiology, you can read about resources, finances. So it just gives you a little flavor and it gives you that introduction. And if you do like it and want to do more, you've got those options of whether you want to do the fellowship, the ACP. But again, the learning, if you were to do this whole toolkit, that in itself will give you quite a bit of knowledge that you can actually translate into your clinical practice. So don't underestimate what you can get from this toolkit. It's sitting, if you did it from back to front, it would take you a few hours. So, but it gives you a good taster. So that is a headline summary of what we're doing. So thank you for the opportunity. And yes, I'm sure there's opportunity for questions at the end.
Thank you so much. It's really, really helpful to have that insight into the fellowship and the other elements of the programme. I'm going to move us straight on now, so we've got good time for discussion later. And I'm going to ask Dr. Esther Miraku to give her presentation, and that's focusing on gaining buy-in from clinicians on their role in addressing health inequalities. And just to reiterate, Esther is a consultant in public health at North Tees and Hartlepool NHS Foundation Trust. So over to you, Esther.
Thanks, Saffron. Can you hear me?
Yeah.
Okay. I was trying to load my presentation at the same time that we were talking. So I'll just quickly, I think the direction in which I decided to take this was to give a reflection of the journey that I've been on since I took up post in this role just a little over a year ago. So I noticed, I don't know how, but I was I was muted in one way or the other. I'm going to talk about the journey that I've been on to try and gain clinical buy-in to support the work on addressing population health and health inequalities. And before I do that, yeah, it's moved now. I just thought we just need to stop short and reflect on a few things about, if we're trying to gauge clinicians, what are some of the things that matter to clinicians? And what are some of the things that we need to consider? And to be realistic about the ask that we're asking of clinicians. For the purpose of this presentation, I'm looking at clinicians not just as medical clinicians, but clinicians, all types of clinicians. So anybody who has face-to-face contact with a patient, I'm defining as a clinician in this sense. And I think it's important for us to understand that the ask of the NHS now to address health inequalities although it was there previously, is still a bit alien to the NHS, and it's a new era. And that makes quite a number of clinicians feel as if it's not really the normal practice in the NHS. And therefore, this is about a cultural change process that we're going through in the NHS, and it will take time. What I've also observed is that for clinicians, for myself as the lead on health inequalities and population health, they need to see me as being visible and authentic and available to them to address any queries or concerns that they may have. And it's also important that as a leader, you make a very compelling case for change with clinicians. I've already mentioned the fact that it is quite new to them. So we need to make the narrative very, very simple and clear. And we need to be realistic about the current pressures on the NHS and on clinicians. And therefore, whatever ask we are asking of our clinicians needs to be very simple and one that they're able to address. And we've also got to make sure that we invest sufficient time to ensure that we understand the authorizing environments through within which clinicians work. We might need a clinician to do a piece of work around health inequalities, but they need permission, because if they have to attend a multi-agency partnership meeting, for example, that's clinical time lost, and they need to be given that time off. At the same time, they might be interested in doing a piece of work, but they need to have the support systems that will help them to be able to do that work. And then the other thing that I think we need to be, and therefore we need to make sure that we've got that executive buy-in to support that change, but also not to be precious about being the ones who will lead everything, and to empower others to drive and own that agenda. And then the other thing is to make sure that we understand the knowledge gaps and the capability gaps that is required in order to take what we are asking forward, and to look at the opportunities within the system. Clinicians, particularly medical consultants, do a lot of clinical audits and quality improvement work. And it's how we work with them to reprioritize what topics they go for when doing those work, and also provide that enabling environment in terms of clinical other pathways that they could refer people to. And then the necessary support systems that needs to be addressed. So I see myself in this role mainly as a system leader and a system navigator and a change facilitator who supports clinicians to be able to take the agenda forward. And in order to be able to do that, there needs to be different levels at which I have to support and influence. And this is mainly at board and executive level. At the moment, I've done quite a number of presentations to our board, and my focus was to be able to get our board and executives to act as champions and advocates for health inequalities within the trust. And then with the clinical directors and our other directors as well, for them to act as the enablers to support our clinicians, who are then, and the clinicians are the ones who implement the change. And the other thing to look at is, what is the vision that we're working on? It needs to be very clear, such that everybody is clear exactly where we're going, in what direction we're going. And my focus has been support to staff and support to improve inequalities for patients and carers in working with clinicians. And there are a certain set of tools that are required in order to support staff and clinicians to take this forward. I think one thing that I need to make clear is that for a clinician to be engaged in the journey that we're going on to address health inequalities, they cannot do it by themselves. They cannot work in isolation. So it needs to be a whole organizational approach, because it's a cultural change that we're driving. Other members of the organization would have to support the clinicians in order for them to be able to make the changes that needs to be made, even if the clinician wants to drive those improvements. And some of the tools, I could go on a whole long list, but some of the tools that I've been using is the approach to communication, the narrative that I use in-house to get the attention of clinicians at different levels. And then using data and intelligence, that's one of the key drivers, but trying to simplify the data and intelligence that we've already got such that it's easily understood, and also trying to understand the knowledge, capability, and capacity of clinicians and how we can support them in different directions. And then we've also developed a strategic framework that makes very clear what programs and services that we need to focus on. And in developing the strategic framework, I've looked at the NHS planning guidance. And then in the Northeast ICS region, our colleagues in OHID have worked to develop a health inequalities toolkit for acute trusts. So we've used that as well to look at the opportunities within that toolkit, and then looked at the leveling up agenda and all other policy drivers that need to be looked at to help us focus and say, from a strategic framework perspective, this is what we're doing. Within our trust and our organization as well, there's a project management improvement support office that's been set up within the trust. So if a clinician has to lead on a project, there's that project support officer that's able to support them. And there are other support systems such as business support officers, BI intelligence leads as well. This next slide is slightly busy, but it was just to take you through some of just a sample of the approaches that I've used for engagement. So at board and executive level, our chief executive is now the senior responsible officer for health inequalities. And we have set up a health inequalities oversight group and brought in multi-agency partnerships who provide the challenge across the system. And that includes our 2 local directors of public health in the local authority areas that we drive, and our place directors from the ICB. And all the directors, basically all our corporate directors, sits on that group and is chaired by our medical director. And that is just so that we've got that senior clouds and leadership buy-in. So when other clinicians are going to lead on projects, they know exactly the support that they've got. Within the executive team as well, I've done a number of sessions with them. So our executive team are also champions for health inequalities. And then I've attended the board seminar. So, and the whole, our trust board, all the members have agreed to be champions and advocates for health inequalities. And there's one non-executive director who has, as part of his portfolio, leadership for health inequalities and equality, who also supports very much with us. And he chairs the transformation committee. So health inequalities is driven very much through our transformation agenda. It's across board. From directors and clinical directors perspective, we've got our trust directors group, and I'm part of the trust directors group from health inequalities perspective. So I sit as part of that group, and we have a standing agenda on health inequalities to understand what we're doing. And through that group, what's then happened is that the clinical directors have created that opportunity for me to attend each specialty area, their clinical governance meetings, and had conversations with senior managers and the rest of the consultants within their directorates around health inequalities. And we also have what we call the grand round sessions. That's a monthly session, CPD session, and that's open to any member of staff within the trusts. And we've done, in August, I put on a session on population health and health inequalities in healthcare settings. So that's generated a lot of interest across the trusts. And this month, in actual fact, is next week, my colleague from the Mental Health Trust is coming to do another session, a follow-on session on that, so that we look at the synergies between mental health in health inequalities and the role of the trust as part of that. For senior managers and medical consultants, as I said, I've been through all the different directorates. I'm yet to go to the medical education team for the doctors in training session, but I'm in conversations with them. So for the doctors in training, I have a number of training sessions for the junior doctors, for the foundation doctors, for the specialty specialist trainee doctors, and also for the medical students. And then we've funded through our workforce team and Making Every Contact Count CPD model through Teesside University. For other medical stuff, I've mentioned that already. And then from the previous presentation, you heard about the Population Health Fellowship Program. So we're hosting 2 Population Health Fellow that I provide educational supervision for. One of them is a GP trainee, and the other one is a physiotherapist. But that's been an opportunity to provide additional public health skills to other members of the trust. And we've also opened up this in the Northeast. There's a foundation program in public health. That is the first cohort will start in January. And we've opened that, and I've supported a member of staff in the trust as well to be part of that program. So in terms of other clinical staff, again, we're doing the making every contact count, train the trainer work. And that is across board, everybody, basically, it's open to everybody. And just last week, we agreed with our director within our trust. We've got the NTH solutions team who employ all our domestic staff, our porters, etc. And we've agreed through that route that we're going to train every member of staff through that route on making every contact count. And the whole idea is that they have a lot of conversations with patients, particularly when they're on the ward, as they support them, clean them, etc. They have those one-to-one conversations that a consultant may not have the opportunity to have with patients. And it then provides that opportunity for those members of staff to flag any issues with the clinical team, such that the clinical team could take them up as part of any improvement work that we need to do. And then as part of the rest of the non-clinical staff as well, we've in the Northeast, again, there's a training, health inequalities training that's been provided for trust analysts to help them understand how to do analysis with a health inequalities lens. So we've got 3 of our BI team who are going to start that training in January. And my next slide is to just take you through, so when I attend, let's say, a clinical meeting, the kind of conversation that I have with our clinicians in general. I've talked about the fact that we've developed a tool within our trust on health inequalities. We've got a health inequalities dashboard, and that gives us a very broad overview. Diagnostic is just a simple diagnostic tool, very broad, just focused on trust data. We've reorganized our trust data to help us understand health inequalities within the trust. And I'll go to the next slide and come back to this one again. From the health inequalities dashboard, when I go into a clinical governance meeting, I go to the specific specialty data, and I take them through the journey of what's happening within their directorates. So in this particular slide that you're looking at, that's our referral to treatment profile. What you'd notice is that on the bar charts where you've got a lot of oranges, the orange is our patients from quintile 1. So automatically it's very visual to the clinicians that compared to our expected population, which is the PHE catchment IMD profile that was developed for us just before Public Health England changed. Close to 50% of our population are from the 20% most deprived wards. But from what we're seeing, we've got just about 42%. But if you look a bit further down, then you notice the majority of patients who are waiting for a procedure are from the 20% most deprived wards. We then go on to break down into ethnicity, etc., to understand. Because our population is such that from a BAME perspective, it's just about 3% of our population who are from minority ethnic background. So we try to break it down a bit more further, such that we don't just lose them and leave them out of our discussions. And what you notice on the bar chart at the bottom there is when we're looking at the waiting list. So the journey, what I would say to a clinician, for example, is that although you don't have a lot of patients from the BAME background, what you'd notice is that from the BAME background, from people from BAME background, 2 out of every 3 of your patients is from the 20% most deprived wards. And for all the patients on your who come through your consulting room, approximately 1 out of every 2 who walks through that door is from a 20% most deprived ward. And therefore, that starts that conversation about, if that's the case, then what do we have to do about that? And that takes us back to the original slide that I was talking about. And it's about, first, we need to understand what we're talking about when we're talking about health inequalities. And then what are we actually trying to achieve? And the conversation that I normally have with our clinicians is, we've got all our clinical quality standards in terms of NICE guidance, etc. That provides equality for every patient who walks through your consulting room, because you wouldn't use different clinical standards for different patients. But what we were trying to say is that when we only focus on the clinical standards, then in reality, what we achieve is that some patients who are from the most affluent wards achieve the best outcomes of care, and others are pushed further deep down. And as part of looking at things through the health inequalities lens, then what we're trying to do is provide equity and enable all our patients to achieve similar outcomes of care. And what I find is that that simplicity of the message gets our clinicians to listen and to take notice of that. And also, I also then have that conversation about, if we don't do anything about this at all, then what happens? And that's the other table that you've got on the far right hand of the screen. And then I've also been sharing a lot of behavior insight information. Esperia.co.uk has got what analysis on at mosaic level that gives us quite a lot of understanding around the preferences of different groups of people in the population based on where they live, based on deprivation, etc. So we've been having those frank and honest conversations in-house about, if, say, for example, I live within the 20% most deprived ward, then there's the likelihood that one of my biggest priorities will be around poverty. I have issues around childcare that I need to address, etc. I may be working 0 hours contracts, or I may be working a shift pattern. And therefore, by putting up a clinic, let's say from 9 till 5, I might not be able to attend that clinic if you just send me an appointment as a result of your structures that you've got in place. And therefore, I'm likely to DNA, or you might find me to be hard to reach. But on the other hand, if you understood the things that matter to me and the things that bother me, then we could restructure the clinic appointments in order to enable me to attend. And those are some of the conversations that we do have with clinicians. And then also, I don't leave any clinical meeting without saying, and therefore within this particular specialty, these are the opportunities and what you could do. And then there's the final conversation around, and these are the tools that are available to support you. So that's just in summary, that's the journey that we've been on. We're not quite there yet, but I believe we're a long way. We've made a lot of progress in this direction. Thank you.
Esther, thank you so much for that, and for sharing so much of the detail and the genuine steps that you're taking on this. I'm going to move straight on to our final speaker, who is Carolyn Regan, who's Chief Executive of West London Mental Health NHS Trust, and she's going to talk about how boards gather insights from staff to strengthen their understanding of the leadership needed to make progress on this agenda. So over to you, Carolyn.
Thanks very much, Saffron. And I've got a few slides and hopefully a few messages which resonates with the two previous speakers. So I'm Chief Executive of West London, which offers mental health and community services. And I'm also one of the two SROs for the programme with a long title, Proactive Population Health Management and Reducing Inequalities in Northwest London. So what I've tried to do is set out a strategic approach to this, which is on the next slide. And I think some kind person, thank you, is going to help me. So on the left, the legal duties, which will be well known. And then the yellow brown boxes, next ones over, are the frameworks that we use for strategic alignment and the approach, both in the trust and hopefully across Northwest London. So I just want to pick out a couple of things. In the equality delivery system, there is a strong mention of a representative and supported workforce, and that's what we're aiming for, not just a representative workforce, but one that feels supported and valued, and inclusive leadership. And then just going down the frameworks, the core 20+5, incredibly helpful to bring this work into focus. And for us, it's looking at specific communities, people with a learning disability and autism, and people with long-term health conditions. So at a Northwest London level, just starting with the focus on recovering the elective care and addressing the waiting lists and the backlog, we've also done some work on an analysis of DNAs and who does and doesn't get called and admitted, and having the conversation with clinical teams about what we can do to support them to address the higher level of DNAs in certain communities, and usually more deprived and more diverse communities. Similar discussion around, for example, child and adolescent mental health services, where we know that young men or young boys from certain communities don't come forwards, don't get referred, and what can we do to outreach, often through community organisations and faith organisations, into those communities. And then the last point, I think, on this slide, on this page, is about retaining talented, local, committed people. So we've just started offering apprenticeships and placements for young people with a learning disability under the Project Choice banner. And that's interesting in terms of just offering those people a different opportunity that perhaps they've had previously. When I talked to a group of about 15 of them last week, one of them said, I want to be a doctor and I'd like to talk to people who can help me with that. So I introduced him to the medical director, but I thought, great aspiration, and we should be supporting that. So on the next slide, I've gone into a bit more detail about the West London approach. And again, it's a very busy slide, but I'll try and pick out a few key things. I think Esther mentioned the importance of physical and mental health, and that's certainly something that we've picked up. And in developing the physical health hubs, we're trying to address perhaps those unseen physical needs of large numbers of our service users. We've got the usual service user and carer forums and some specific outreach projects where staff have talked to us about working in certain communities, and we found local radio stations a really good way to get some of those messages across. For example, about direct access to talking therapies, and what people can do to look after their mental health, and what to do if they're worried. We have a number of staff networks, and they have a direct line to the board. So there is a board discussion about their priorities and what support they would like. And each of the staff networks is sponsored by a different executive director. And I sponsor the LGBTQ+ network, and again, meet with them as frequently as I possibly can. And then a lot of training for staff. Again, some of it's mandatory. I've mentioned cultural competency there, but also active bystander training, white allies training, etc. And everyone at a senior level has an objective as part of their objective setting on EDI, and it might be about a more diverse workforce, it might be about more diverse senior leadership in their service, and it might be about a service objective relating to diversity. But everyone has one of those, and there's a cascade system starting with myself and the executive team. So what we've done is try to bring together the workforce issues and what we've called the patient services issues, or the service user issues, and that's shown on the next slide. And previously, these were separate pieces of work, and we had a lot of work through the mental health EMHIP work, so a series of service projects to get a better understanding of the disparities in both access and experience and treatment. And we've brought together a program of work, which I'm the SRO for, which is looking both at service users' experience, how they access the services, what they can expect, how we can address some of those disparities, and also the workforce issues, which were to a certain extent being managed separately before. So again, as with the patient services, big emphasis on co-production, so talking to our staff and getting their views about what's helpful, what works, what they would like more or less of. For the first time ever, we've improved against all 9 RES standards in 2021. And obviously, I would say we started from a pretty low base, but that's improvement against all the 9 indicators, and something that we're proud of. And you can see some of the achievements there in terms of increased representation at more senior levels and bespoke support packages for staff. We also, the last point on the left side, we introduced a restorative resolution approach to resolving workplace conflicts, often between managers and individuals in their teams. And we've moved from one of the worst in London to one of the best in London for staff experiencing disciplinaries from varied backgrounds. But all of this takes time and focus and energy, I would say, and it hasn't been done overnight. So in summary, I've written down a few reflections from really focusing on this over the last few years. I would say sustained leadership, not just from me, but from the whole senior leadership team, and a real emphasis that we want to make some progress on this, and this has to run through the whole organization. Authenticity and a clear and simple narrative, so having a story that hangs together, which makes sense to people working at every level of the organization in different services, different sites, different teams, and we operate from about 40 different sites, so making sure that narrative is clear and the visibility is there, and a strong staff and patient voice with ongoing communications and engagement, and also things like recognizing when progress isn't as fast as it should be or could be, and what we can do to unjam the bits that get stuck. So using a QI, quality improvement methodology, using data and evidence and stories and voices. It's all the things that previous speakers said. So I think a really big emphasis on how we can engage our staff further and in an ongoing basis, and just acknowledging all staff are part of their communities, their neighborhoods. They go to faith groups or churches or mosques, or they stand outside school gates, and what can we do to support them and to promote this agenda, which is really important for all of us. Thank you.
Thank you so much, Carolyn, and to Esther and Maz as well. Just really different set of really important presentations there, looking through the kind of what's the education and training program we need, how do we actually do this in practice, and then the approach from the kind of board perspective of engaging, understanding from staff what needs to happen. So I'm going to ask, we've got a few minutes for questions now, so please do raise your hand using the raise hand function, which you'll find under reactions at the bottom of on the toolbar, bottom of your screen. But while people are thinking, there's a really good question in the chat, which is from Natalie, and she's asking, she's a clinical fellow with the CQC, and she's currently working on strengthening evidence on evidence gathering on tackling health inequalities on inspections. And she's asking, how do you think regulators can ensure they better capture innovation and success on tackling health inequalities? So I might come to you first, Carolyn, if that's okay, and then I'll go to Esther and then Maz.
Sure, great question. So I think I would say three things. One, set some aspirational targets so that there's something really clear that we're all aiming for. Make sure there's a narrative about how people have been involved in both designing the targets and contributing to them. And then thirdly, don't ask for data every 5 minutes. I mean, I do constantly say, you know, it's a bit like if you're gardening, you don't pull up the plant and look at the roots and say, why isn't this growing 5 minutes later? You've actually got to give these things a bit of time. So those would be my top three. Really, really helpful. And I think there speaks the voice of experience being the head of the regulators. Esther, any thoughts from you on that?
Yeah, I would say that rather than asking about the outcomes that the organization has achieved by reducing health inequalities, regulators should be more interested in the journey that the organization has started and is going through. Because as Carolyn has started, this is a cultural change that we are all on a journey for. And I think most of the time regulators want an evidence of the outcome that we've achieved by doing A, B, or C. But it's more about how we're supporting our staff, how the board is putting this as an important topic, and what tools we're putting in place to support staff to make it happen. So that would be, yeah, the key bit for me.
I think that point about recognizing progress and where people have got to is so important. Maz, do you have any thoughts on this one?
Yeah, I think just to add what others have said, I think outcomes is quite hard as a regulator to see. I would say look at the strategy of the organization to see whether they are serious around health inequalities and what are they doing. I think we've done a good deal in sustainability, and now every ICS and trust have a green plan. I think if I was going in as a CQC, I'd want to see the strategy and the aims and plans around health inequalities.
Thank you. That's really really helpful. I'm going to ask people if they've got any other questions. Please do raise your hand, put a question in the chat. I'm not seeing anyone. If you don't ask questions, I will. So I think one of the things that I've been struck by, and I think this is a question for Maz in the first instance, is you talked in your slides about the breadth of different professionals who are coming through your program, and I just wonder, you know, to what extent, how are you adapting your programs to accommodate this breadth? How much is there kind of core, you know, the core knowledge and experience versus some of the stuff that needs to be tailored? And kind of interested because I think it gives such a good it's such an open approach. So I just think I'm interested in how you go about that.
Yeah, I think firstly, in terms of population health, what it is changes from where you go. I think the definition we're using is the one in NHS, and it's really around of key focus is looking at the population health level and that focus on health inequalities and the wider determinants. Now, when I was first tasked to set up this fellowship, we first thought about, okay, should we do it for doctors? And then it was like, no, not just doctors, let's cover all clinicians. And then we slowly built up from multi-professionals to then more clinicians, and then effectively now anybody who's got a role relevant to population health or health inequalities. And there were concerns at the beginning whether you can have a paramedic, a GP, a dentist, and a manager all sat around and learning together. Thankfully, what came out in the evaluation is not only was it possible, they also really valued it in the sense that learning together with the other professionals, you see their perspective. So what we took out is in the core workforce, the knowledge around population health and health inequality is quite minimal or at the same level across the whole board. So getting these people to learn together is possible. Now, when I look back to when I was in medical school, which was, I can't remember, but yeah, like I didn't get that much. Well, let me not annoy my medical school. I didn't get enough around population health and health inequalities. And having come out, everything that I have learned is more around my clinical passion and interest. I don't think there's enough of it in the already established training programs. So that's why we've been able to basically uplift everybody, because a lot are around the same level.
Thank you. That's really helpful. A couple of quick questions have popped up. So one is for Esther, which is how long might it take to achieve the HI training for a trust analyst or BI team? Don't know if you have an answer.
Yeah, I've just put a response there.
Oh, sorry, I didn't see
it's our colleagues from OHID who have put the program together, and we, as consultants in public health in acute trust, work jointly with them. It's just a half-day CPD session, and it's just to give them the ideas of how to do analysis. So it's just half-day.
Thank you. Thank you. And I think that's a really important point, isn't it, about people understanding that the amount of time that they may need to commit to that, and sometimes it perhaps being a shorter time frame than people might expect in terms of different bits of commitment. And then there was an interesting question there for you, Maz, around is there value in supporting at least one clinician from each specialty in a trust to undertake one of the levels, or is that excessive? Can you see that in the chat?
I don't think that would be excessive. I think what our target now, because we're starting small, is we're trying to cover every region in England. And I think then we want to cover every ICS and hopefully filter down. And as the numbers increase, I would have hoped that there's more than one person doing population health and health inequalities in a given trust. So yeah, I don't think that would be excessive.
Super. I'm keenly aware of time, and I don't want to keep people on beyond our allotted hour slot. So I am going to draw this session to a close. I want to thank all of our speakers, Carolyn, Esther, Maz, for their presentations and contributions. And I know that there have been some really helpful slides and narrative there to help you all on your journey in terms of thinking around kind of learning from the health inequality space and what it means to really implement this and start to get under the skin of tackling health inequalities a reality and part of day-to-day work. So thank you all for coming along today and contributing. The event has been recorded, so people will be able to watch it back if you want to look at the presentations again or think about any particular element of it, you will be able to access it. So thank you very much for attending. Thank you again to our speakers, and have a good rest of your days.